Hopefully you're seeing what I'm seeing now.
Yes, I can see.
Excellent. Thank you very much, Tariq.
Yeah.
I'll just give another moment just to sort my own camera.
Yes.
And hopefully everyone can hear me clearly as well.
Yes, I can hear you very
Lovely.
clear.
Okay, I shall get started. So, Tariq, thank you very much for the
Thank
invitation.
you.
It's a great pleasure to come over here, and to Ali as well, who offered me the
Yes.
opportunity to present over here. So, thank you to both of
Ali,
you.
Ali is here. Ali is here and
Hey,
saying,
Dr. Bustani.
How are you doing, Ali?
Fine. Just want to say that Dr. Bustani is one of the greatest consultant I've ever dealt with, and he's also very good on the person side of like working with in Sheffield. And I hope you all enjoy the session. And please, Dr. Bustani, please start whenever you're ready.
Thank you very much. Thank you so
thank
much for
you.
those kind words.
Thank you.
I'm now worried I'm going to let you down so much. So I'll try to be humble with this. Okay, so I'm going to spend a little bit of time sharing some slides with you. It's essentially going to be about high frequency ventilation, as well as the volume guided side of things. I'll try and touch on some of the theories behind it, some of the research, but also some of my experiences. And what I hope to have is some time to answer some questions at the end of the presentation with you, but also maybe to ask you a few questions as we go along. So there may be the opportunity to do some Menti questions. So somewhere during the presentation, hopefully this will work. I'll put up a QR code. And if you can take a photograph of that, then if this works, then I'll be able to go and get an idea of the spread of answers in a couple of scenarios in there. I do apologize if it doesn't work, and unfortunately, because of the restrictions, it only allows the first 50 answers to come in. So we'll see how that goes. So let's get started. So as I say, the talk was supposed to be how to ventilate using high frequency oscillation volume guided mode. But I think that as a title, the word how to do it is going to be different. I'm going to say how I ventilate using high frequency oscillation volume guide, because there is differences between different people's practice, because the evidence base here is not so great compared to some of the other practices that we do in neonatology. And before I go into the volume guided side of things, I think it's very important that we all appreciate how we use high frequency oscillation without volume guided, because if you can't do one, you won't be able to do the other. So we'll concentrate on those as well. We'll try and touch on some of the theory, what's the research base out there, a little bit of my clinical experience. I hope to hear some of your clinical experience. And then, as I say, we're going to try and touch on what benefits there may be from using the volume guided forms of ventilation. So if we're going to talk about high frequency oscillation, we need to talk about high frequency oscillators. Now, I've been probably older than many of you over here, so I've seen many of the ventilators for over the years. Certainly used the SensorMedics as my first introduction to high frequency oscillation. And then we had these little baby log ventilators from Drager as a very, very junior doctor. And they were able to do a number of different modes of ventilation, but very little power and very little in the way of monitoring. And then different manufacturers started producing their own ventilators, specialized in neonatology, but also with the capacity of providing high frequency oscillation. Well, we were lucky enough in the early 2000s to purchase one of the very first VN500s. So I think we got the first ones in the UK after they'd just been developed, and were involved in the feedback that led to the different improvements in that ventilator. But something you may not be aware is just after the release, we met with the engineers because they were having some problem with the monitoring side of things when it was using nitric oxide. So as a result, they had to go and choke down the power of the VN500 in high frequency oscillation mode, and we had to go and look at ways of still providing effective high frequency oscillation when they had reduced power output. Now they've improved that, and so with the VN800, those things have been improved to a degree, but it led to some difficulties in using the oscillation mode on the VN500 when you compared it with the incredibly powerful SensorMedics oscillator. But the benefits were still there enough that we carried on using it. So I don't know which ventilators you're using on your neonatal unit. And I will go and say that what's very important is that you know how your ventilator works. It's essential you understand. So every mode of ventilation we know has a learning curve and its own idiosyncrasies. Sorry, I'm just hearing somebody's voice there. So every mode has a learning curve and idiosyncrasies, and high frequency is in particular one of those modes that can have a lot of problems when you use it. And if you're not using it as a tool, it can be unfortunately used as a weapon. It can be very harmful to your babies if you do not know how to go and use it. So we need to learn about our modes and we need to learn about our own individual ventilators. So how does high frequency oscillation work? We're going to take this very much from basics. We all, I'm sure, have an understanding of neonatal respiratory physiology. So we all know that oxygenation improves. Generally, two main categories. You increase your FiO2, your saturations go up. And if you're on a baby on respiratory support, if you increase your mean airway pressure, you improve your oxygenation as well. When we're talking about conventional ventilation, we talk about mean airway pressure being as a result of PIP, PEEP, slope, and IE ratio. But those don't hold when we talk into high frequency oscillation. And what we know when you have an increased mean airway pressure is that the lung expands, and then the amount of surface area exposed to be in contact with the atmosphere and the oxygen increases, enabling improved oxygenation. So we do need to go and make sure that we are opening up the lungs so we can oxygenate the baby. But it's not just about the airways and the alveoli. We also know that the vasculature changes in terms of its perfusion depending on how much opening of the lungs we have. So we want to avoid VQ mismatch while also having a look at the lung airways and surface alveolar recruitment. So this is a very old diagram, many of you will have seen beforehand, which shows that as your lung volume increases in size and you reach your total lung capacity, you have a change in your pulmonary vascular resistance, such that when the lungs are completely closed, perfusion through the lungs is impaired because of very high resistance. As you open up the lung and approach your functional residual capacity, pulmonary vascular resistance reduces. But then as you overexpand the lungs, you then start to lose the lung perfusion if you're not careful, because the resistance goes up as well. So we have to be mindful when we're recruiting the lung that we do not under-recruit or over-recruit lungs. So these are things that we have to take into account. So how are the mechanics working if we want to go and oxygenate a baby? Well, oxygenation is simple. You have gas flow in with blended air and oxygen that travel through the inspiratory circuit, come through to the expiratory circuit, and there's an expiratory valve which partially closes off, and it provides essentially what would be the same as giving CPAP on a ventilator. So the expiratory valve closes, generating CPAP, and if the pressure in the circuit is the same as the pressure in the lungs, then the lungs are held open in a constant manner, and you won't get gas flow going in or out if the lung pressures are the same. So this is good for oxygenation, and for any of us, if we expand our lungs and we're full of oxygen, we don't have to breathe at all. The oxygen in our lungs will diffuse into our pulmonary vascular circulation, and as long as there's a concentration gradient between our lungs and the pulmonary vessels, oxygen will make its way through. So just lung inflation is sufficient with a certain mean airway pressure to oxygenate ourselves. But if we're not expanding and de-expanding our lungs, we are going to run into problems with a high carbon dioxide. So we want to work out a way of getting rid of carbon dioxide. And this is where oscillation differs from conventional ventilation, is that we produce these oscillations which are generated within the inspiratory valve limb for most common old ventilators. So we generate fluctuations in that mean airway pressure, which are then transmitted down to the patient as well. So this is what differs these from other babies. Now, in the old ventilators, This was generated using with this, what effectively looks like if you're using old hi-fi speakers, this was basically like a boom box at the back of it. And this diaphragm pulse in and out, generating what could be extremely powerful oscillations, both positive and negative. And the important thing about a true oscillator, it generates positive and negative pressures using this. So this fluctuates around the mean airway pressure to produce these changes in amplitude. Okay, so our inspiratory circuit has a mean airway pressure, but around it we have a pip and a peep effectively, but these pressures are not the same as what is happening in the lungs, so totally different from conventional ventilation. And it's quite easy for these pressures to become negative, so they can drop to a suction type pressure. It doesn't even have to stay above 0. And these amplitude oscillations, this is what determines our carbon dioxide clearance. The mechanics and mechanisms of it can be very complex. If you want to think about it in the very basic form, if you have a piston pushing a gas column along a tube, if you push it in very quickly, it ceases to have a rectangular appearance with a flat interface between the gas and the old gas. As the gas is pushed, it basically makes its way to the center of the airway and forces itself into a peak. Okay, and if you do that very rapidly with sudden arrest, you get accelerated diffusion. So a small amount of gas that's pushed in can be channeled through the center of the airways far down the alveoli towards where the alveoli are in the terminal airways. So you can really go and push the gaseous exchange below levels that would be considered to be normal dead space. It's far more complicated than that, and lots of work has been done to look at the mechanisms that high frequency oscillation works. And I think it in fact, worked the wrong way around. People didn't have the theories about how it worked and then tried it out. They tried it out, found out it worked, and then had to go and work out all the mechanisms by which it can work. And so there are lots of different mechanisms by which high frequency oscillation works, and we're not going to cover that in this situation here. So what are the potential benefits for using high frequency oscillation? Well, people will say the advantages are you have less chance of barotrauma, less chance of volutrauma to the lungs. That's why they want to use it. And it's extremely effective at carbon dioxide removal. So those may be some of the benefits. However, what are the potential disadvantages? So despite what we said initially, you can potentially get more barotrauma and volutrauma to the lungs, which can be easily undetected. Okay, so these things can be masked and hidden in ways that with conventional ventilation, you're sometimes far more aware what is happening in the background when you have very large tidal volumes of babies. These can be missed with high frequency oscillation. And
Hello, Dr. Boris. We cannot hear you. I cannot hear you, Dr. Boris. Can you maybe unmute you? Yeah.
Yes. Can you hear me again? I think somebody silenced my microphone by accident. Okay,
Yeah.
I'm back.
Yeah.
Okay.
Yeah.
So we have to ourselves know who are the patients that will benefit most from using high frequency oscillation. And the difficulty is the research studies weren't designed to go and see who are the babies that best benefited for this. Are they the babies who've got cystic pulmonary interstitial emphysema, chronic bronchopulmonary dysplasia? Is it for preterm RDS? There's separate work that's been carried out looking at the use of high frequency oscillation for babies with congenital diaphragmatic hernia. I shan't be covering that particular condition over here. So we'll just talk about the basics of it over here, and we can have maybe in the discussion area those other zones. So who would benefit from this most? So if you just take a quick photo of this with your QR code scanner, I'm hoping this will take you through to a couple of questions. So have a peek at this. So if you're taking your photos over there, So we're just going to start off with a very simple question for yourselves. So the question will be, what would you use for a baby? Let me see if this moves on. What ventilation method would you currently use for a baby born at 25 weeks with respiratory distress syndrome? What's your usual approach to ventilation? High frequency oscillation, high frequency with volume guided, one of the conventional forms of ventilation such as PCAC or SIMV, or PCAC SIMV with volume guided ventilation.
We can see different question, unfortunately.
Oops. In fact, that's a very good, yes. I don't understand why that is. It should be. Oops. Is that still the case?
We can go back and do screen again for.
Okay, I'm starting to get some responses in there now.
Okay.
Okay, so at the moment, the responses I'm getting seem to be predominantly conventional ventilation with the use of volume guided ventilation. Okay, so option 4 seems to be by far the highest out of these categories. We have a couple of people who've mentioned high frequency and a couple of people using high frequency oscillation with volume guided, but by far the majority of people are using option 4, so PCAC or SIMV with volume guided ventilation, which according to NICE guidance would be the correct answer. So well done, everybody. That's absolutely fine. But there are people who are potentially using one of the first two. So as I say, I just wanted to get a feel for what it is that people are using out there in the real world routinely for these patients. Okay, before we continue. So much of the early work that was done with these with this mode of ventilation was first explored with animal work, and the animal work suggested that this was going to be fantastic. They started with animals and found that they had less barotrauma early on, reduced inflammation, and when they saw these animals develop on the oscillator and then they came off, they had better alveolar development as well compared to positive pressure ventilation. So this was felt that this was going to be an absolutely fantastic mode of ventilating patients. And so work was done to go and see how this would benefit babies, either as rescue therapy or as an elective form of treatment. So early studies were done. And so when the early studies were done, the very first one, the big multi-center study, was the HI-FI study. Lots of babies. Now, in the way that they did high frequency oscillation very early on, they used something called the low volume strategy. So you essentially started the baby on the same mean airway pressure as the baby was having on conventional ventilation, and you kept them pretty much there, and then you titrated up and down your oxygenation with that. And with that, they didn't find much benefit in terms of chronic lung disease or survival, but what they did find was an increased risk of grade 3 or 4 IVH. So there's a lot of disappointment at the time about using high frequency oscillation. And so there were some people who decided this probably wasn't the future. And then there were other people who thought, well, maybe we're not doing it in the correct way. So every tool needs to be explored to see what's the correct way of doing it. And that's where sometimes doing more extensive animal studies is the answer to go and explore in this area. So then the multi-center studies were refined in ways that use something called the optimal lung volume approach. Okay, so we've talked about what we'll call the low volume approach, then it moved to a high lung volume approach, and then finished off with something called the optimal lung volume approach, which we can talk about later on. So the two biggest studies in this were back in 2002, and they were both published in exactly the same journal, in that particular issue in the New England Journal of Medicine, and one was the American study by Courtney, USA, high frequency study, and there was the UCOS study carried out and run from the UK. So many hundreds of patients were carried out there. So the United States study, the baby pretty much stayed on high frequency throughout its duration. And with that, they saw that there was improved survival without chronic lung disease at 36 weeks, statistically significant, but a small benefit in those. And they managed to get their patients successfully extubated earlier than those in the positive pressure ventilation group. So they saw some advantages to that in that use there. In the UCOS study, which had more patients in there, they limited themselves to the first 120 hours of life using the optimal volume strategy with high frequency oscillation. And they didn't quite see the same difference as the American study. So they said it was equivalent benefits compared to conventional ventilation. So we had two studies not showing a dramatic improvement, maybe some benefits in the American study, and maybe that was because they continued oscillating the baby for a longer period of time. The UK group continued looking at their patients' long-term respiratory follow-up, and there seemed to be benefits after the first few years of life in their respiratory outcomes. However, they've recently reported the outcomes for patients up to 19 years of age, most recently, and those benefits have been lost. Another large study carried out in the years afterwards in 2014 from China by the Sun Group. So they compared high frequency oscillation versus SIMV with pressure support, and they showed some significant improvements there. Certainly in death or BPD, high frequency oscillation had much improved outcomes, and they had lower rates of cerebral palsy, and they had better MDI outcomes at 18 months of age. So the question is, why were they showing such benefits with their approach to high frequency oscillation compared to the other two studies? Was it because the machines had improved during that time? Was it our general respiratory management of patients had improved? Were we better at high frequency oscillation? Or were they maybe not very good at using SIMV with pressure support? So lots of questions. That's why that's why meta-analyses are required in this situation. So where meta-analysis was carried out, and the last one that was carried out, the larger one, was in 2015. And here we can go and see, when you look across the stream of studies ranging from 1992 right through to 2014, the only benefit wasn't in terms of survival, long-term neurodisability, short-term neurodevelopment. It was in a slightly reduced rate of chronic lung disease. So I suppose the question is, should we now switch across to using high frequency oscillation as our standard mode of ventilation? In fact, I'll ask people to go and put that in their notes just now. How many people would think, as a result, we should go and commence as our standard form of using oscillation as our standard form based upon this? No, we're not doing it, are we? So we've not decided to do it. And the reason why is because none of these studies were comparing high frequency oscillation with the mode of ventilation that everyone, or the majority of people here, have said that they would use, was using volume guided conventional ventilation. So we were comparing this new modality, high frequency oscillation, with a mode of ventilation that we would not be using anymore. We wouldn't be using standard PCAC or SIMV anymore. We'd always be using volume guided. So this would be probably lost if we compared it with volume guided ventilation, because we know PCAC, the volume guided, has been shown to be beneficial compared to PCAC. So there's no point showing that HFOV is better than this modality. We should be comparing it with this. And in fact, should we not be comparing HFOV with volume guided with PCAC with volume guided? So the correct comparators have to be used. Otherwise, we can't take the outcomes of these studies into real life. So I mentioned these studies were using optimal lung volume. So what did I mean by optimal lung volume? So we'll just do a little demonstration for that. So this graph over here is, I think, a nice indicator of what we're trying to do. We all know what our pressure volume curves look like in the lung. So you've all seen this in physiology. As your lung pressure is increased, the lung volume increases. And we know that that doesn't follow a straight line. It normally follows a sigmoid shape. But we also recognize that when you inflate the lungs, it takes a different shape, this curve, when comparing to deflating the lungs. So due to lung hysteresis, lung inflation is different to lung deflation. And when you look at here a set of lungs that are obviously not belonging to a person, that have been taken out and connected to a to a CPAP device effectively. So we're installing pressure here. We're at 0 pressure. We increase the pressure to 4, the lung is still collapsed. Pressure to 8, the lung is still collapsed. We then start to get lung opening when you get with this set of lungs to a pressure of 12 centimeters. You then expand the lungs up to 20 centimeters of water. And there you can see that the lung becomes beautifully recruited at this point. As you go a step down with each of these individual pressures, going back down again, it does not mirror what we were seeing on the inflation side. And here you can see as we come down on the pressures, even at 8 centimeters, the lung is very nicely inflated compared to where it was on the way up. And it's only at the latter stages that the lung collapses back down to 0. So the idea is with this, and as people did more and more work looking at the animal models, they realized that keeping the lung open at this low pressure was not the most effective way of managing the baby. Probably the best way to have optimal lung volume is to recruit the lung and then reduce the pressures to maintain the lung in an inflated form at the lowest possible pressure here without causing de-recruitment. So this was used as the basis for the studies going forward and as the practice used for normality. So we tried to go and use an open lung strategy with high frequency oscillation. And here's an example of how we might start recruiting the lung. We know we've got our hysteresis curve. We've got our lung volume on the y-axis, and we've got the pressure on the x-axis. And then what we'd like to go and do is inflate the lung with increasing pressures up to a point where we think that the lung is well inflated but not over distended. And then we wish to go and decrease that. We can remove the volume moniker on the left-hand side and replace it with the word FiO2. Because what we'll also note, because we can't measure lung volume that easily in these lungs, but we know that our FiO2 requirements change as the lung inflates. So when the lung is completely collapsed, we are needing 100% oxygen and we won't be saturating. As the lung is recruited, we reduce to 50%. We'll then reach a point where we will hit a minimum FiO2. So in babies with RDS, which is mild, that may be able to achieve oxygenation in air. But with patients with bronchopulmonary dysplasia or PPHN, there'll be a minimal value which will be higher than air, and will not be able to go below that under that acute situation. So we have to always be wary that if you try to go and recruit the lung aiming for air, you may not reach that point and you may damage the lung trying to reach something that's unachievable. If you then continue to expand the lung, then for the reasons we were talking earlier about pulmonary vascular resistance, then the lungs will no longer perfuse and the oxygen requirements will creep back up again. So we have to be aiming for this zone over here, but we have an unknown FiO2 that we're aiming for in this situation. This is a very old video that can be shared, that's be found on YouTube, which shows a comparison with conventional ventilation with I think this is a pig or a sheep lung, and it shows you how the lung is recruited. And what I want you to take a good look at is the surface of this lung, where it smooths out as you recruit it, but also as we reduce the pressure going into the lung, how it maintains its shape. So here is having conventional ventilation. So this is not on the SensorMedics. This is lung being conventionally ventilated. So certain areas are inflated and becoming smooth on inspiration, but on deflation, the wrinkles appear. And then there are other parts of the lung which are never being recruited at all. They then connect this lung to the oscillator and commence the oscillation. And now you'll see the vibrations start. The mean airway pressure is increasing, 14, 15, it's working its way up. And as the pressures are increasing, the lung is expanding. As the lung expands, these areas are becoming fully recruited. See here, seeing these gaps in between and the creases, lung is being nicely recruited, and those areas of atelectasis are being lost. So we're now on a mean airway pressure of 27, a very high mean airway pressure. Please don't use that at home under normal circumstances. And you can see areas over here where blebbing is starting to occur. And these are precursors to a pneumothorax or cystic PIE in this lung over here. So we always have to be very cautious when we expand the lungs that certain areas which are more compliant will become over distended. They're now decreasing the pressures bit by bit, bit by bit. And despite this significant drop in the mean airway pressure, the lung has kept its shape as it was at pressures of 27. So we're able to reduce that pressure and maintain lung inflation. So it's a useful way to think that what it is that we are trying to achieve with the oscillator with these patients. So back in 97, they described this as what our ambition should be when we're oscillating a baby. We recruit the lung out of the area of derecruitment and atelectasis, get the lungs fully expanded, briefly into the zone of overdistension, and then reduce the mean airway pressure to get to what would be considered the sweet spot, the target point. At this point here, the lungs are nicely recruited, not overdistended, at a minimal mean airway pressure underneath which we will start to get derecruitment. So all the alveoli are sharing the workload between themselves. With derecruitment, certain alveoli are not contributing to gaseous exchange, putting all the load on the others. Also, we know that compliance is determined by change in lung volume for a given change in pressure. That means we ideally want to be where the slope is at its steepest. There's no point having this slope at its steepest at this point over here. We may as well keep it at this point over here. So here, small amplitude changes will produce larger changes in tidal volume. So we can put the minimum effort in the amplitude as well. So these slides are very much about recruitment of lungs for oxygenation and how is it that we are supposed to be trying to achieve optimal lung recruitment. So it's the increasing and the decreasing. So here could be an example. I have a baby who's on conventional ventilation. They're in a lot of oxygen. I will start them on high frequency oscillation and we'll say it's because the baby's got very high carbon dioxide, but I need to start the baby on a mean airway pressure. Now, opinions and approaches change between different people's starting mean airway pressure. For many people, they will start on a mean airway pressure of +2 above what they were using on conventional ventilation. Others will use it maybe +4. For me, I'm always most worried about overdistension of the lungs. And I like to go and start at a lower point. So I always start at my mean airway pressure matching conventional ventilation, knowing that that will not be enough. And that way I can then start increasing the mean airway pressure and making sure the lung will do as I expect, i.e. my oxygenation will start to improve. So let's go and say I start the baby at a mean airway pressure of 10, my saturations drop and I'm now needing 90% oxygen. So I know that I'm unlikely to be overdistended in this situation, because this is my fear, overdistension. I'll now increase within a minute or so up to a mean airway pressure of 11, and I'm hoping now that my saturations will start to increase. That gives me the reassurance that I'm beginning to recruit my lung. After another 2-3 minutes, and when I reach a new plateau, I'll increase to 12. My oxygen requirements have now dropped to about 50%. That's great. It's not where I'm after. I want to go a little bit more. Increase to 13. Go to response. Increase to 14. And then maybe increase to 15. At some point, we need to determine what is our limit that we're going to choose. That can be based on a number of things. It might be as simple as, let's try and get down as close to air as possible. I think that is dangerous. To try and aim to get in there. Some practices will suggest getting down to less than 30% oxygen, and that's the aim. But another way of saying it is that if you increase the mean airway pressure, your saturations go up and you're able to go and wean your FiO2 That's really what you're looking for, is responsiveness. And as long as you increase the mean airway pressure, your saturations pick up and you can decrease your FiO2, you are probably on a recruitment stage for your lungs. You may choose a number at which point you wish to stop and take stock of, well, you want to take stock of where you are. And certainly for me with the preterm babies, I'm using 18 as a point where I wouldn't go any further for an extreme preterm baby before doing an X-ray to make sure I'm not over distended, because I'm always worried about that extreme preterm baby. So let's get to the point where we are no longer improving our oxygenation with increasing mean airway pressures. So I think fantastic, but I'm not going to accept that. I'm now going to be in my going down phase. So I'll go from 15 to 14, 14 to 13, and I'll keep going down until suddenly my saturations are starting to drop and my FiO2 starts creeping back up again significantly towards the 40-50 margin, and I know I've gone too far. I don't stop here. I'll turn my mean airway pressure up by a few centimeters for a couple of minutes to re-recruit the lung, and then I can go and reduce it back down to where I will consider the sweet spot, which for here will be maybe 11 centimeters. So now I'm on 11 and I'm down to maybe about 25 to 30% oxygen, whereas beforehand at 11, I was in 80% oxygen. So I now feel that I have a recruited lung. So this is what we call the optimal lung recruitment. So I say in the very first studies, they used the same mean airway pressure as we use in conventional ventilation, and we had increased IVH rates. Then they did studies looking at a high lung volume where they tried to overexpand the lungs. And I remember as a junior clinician, that's what we were taught to do. And then we moved to optimal lung volume recruiting and then de-recruiting the lung to where we consider to be the sweet spot. Okay, so putting that into practice. So which are the babies that we think that we should be using it? I think there's a general acceptance for most people, if they're using it as a rescue therapy, that it will be used for babies with homogeneous lung disease. It's not really at the point in practice that all babies with lung disease get used with high frequency oscillation. I noticed, Tarek, you mentioned that in Japan they're using it, and that's certainly in the case for the 22-23 weekers, that's their standard approach for ventilation to protect those very, very delicate lungs. But in most units, the standard approach would be to go and use it where you've got more severe lung disease, where it's homogeneous. Okay, and when we're talking about recruiting and de-recruiting lungs, that would make most sense if we got homogeneous lung disease. However, there are another group of patients as well who have uneven lung disease, so it's heterogeneous, it may be cystic in certain areas, and there you may have caused that damage by using high conventional pressures, very high pips, with a great difficulty in removing CO2. So in those situations, we may choose to go for a damage limitation approach to get rid of the CO2. So using lower mean airway pressures, accepting a higher FiO2, maybe saying, I'm not going to try and get this baby into less than 60% oxygen. I'm not going to over recruit this lung because it's already damaged. So I'm going to aim for, in this case, aim for maybe an FiO2 50 to 60%, but just get the carbon dioxide more effectively. Certainly for patients with established pulmonary interstitial emphysema, and even those patients with pneumothoraces, there is shown to be benefits from the use of high frequency oscillation. So I think for these two groups of patients, it can be used, one, to avoid lung injury in the first place and to recruit the lung for rescue, and then for once established lung disease is there, maybe using it in those patients before you make it worse. We talked about oxygenation. We need to get rid of the carbon dioxide. And how you go about doing that is going to depend on the ventilator you're using. Many people, they still love the SensorMedics oscillator. Certainly a few of my colleagues remember the good old days when there was a SensorMedics and you could oscillate a patient of any lung disease of any weight. And while there are certain benefits from power, you don't have some of the monitoring capabilities and the flexibility of the newer ventilators, which we can use. What sort of frequencies do we use? Well, certainly in a very powerful machine like the SensorMedics, you can use really quite high frequencies. So a minimum of 10, you really don't need to use frequencies less than that. We'll talk about frequency later on. Whereas in the less powerful oscillators, you often have to use a much lower frequency range to be able to get the power to do what you're after. And we'll talk about frequency in a little while. So what are the approaches to starting the CO2 removal? Do you start an amplitude to go and get some wobble in the chest? How much amplitude should you check? So when I was first taught how to go and use oscillation, I was told pick an amplitude. That's about double your mean airway pressure. That's a good starting point. Get it started and then adjust it upwards until the chest of the patient starts to wobble. Then I was taught subsequently by other people who were more learned and more experienced, actually that's not going to be enough. You want to go and increase it until maybe the abdomen starts to wobble as well. And then you probably got your main assessment that you've got sufficient amplitude. And then you do a blood gas, and then the carbon dioxide will tell you whether you've overdone it or underdone it or got it just right. But as our ventilators started to improve in terms of the mechanisms of feedback and monitoring they could give, such as the VN500, we were now able to monitor what the tidal volume was mentioned. In fact, even the old baby log ventilator was also able to go and display a tidal volume. So people started to get an idea about what sort of tidal volumes would give you an approximately okay carbon dioxide. And we tend to find between 2 and 2.5 mils per kilo would often give you an optimal CO2. And then you could adjust it after you do your gas. But the important thing is you have to do that gas soon, because it's so effective at getting rid of carbon dioxide. You know, oxygenation can be quite effective, but CO2 removal, it can be extremely effective. And the next thing you know, you've done a blood gas at an hour and the baby's CO2 was 2 or 2.5, and you realize that you put this baby on the path to periventricular leukomalacia. So it's essential that we monitor that CO2 removal very quickly, and you really need to go and do a blood gas very soon after you've established it. And in a machine such as the SensorMedics, that's particularly the case. And I would always be told you need to do a blood gas within 15 minutes of starting the oscillation on the SensorMedics, because you really don't know how effective your CO2 removal is going to be over there. So CO2 removal, we know in conventional ventilation, there's a simple formula for that. Minute volume equals the tidal volume, although we have to remove the dead space, multiplied by the respiratory rate. A nice, simple linear correlation between the two. Well, it would be nice if it was simple as that in high frequency, but that's not the case. It's high frequency oscillation. We use a measure called the dCO2, so diffusion of CO2 measurement, and that's displayed on all modern high frequency machines. And how do they get that number? Well, they get two numbers. They get the frequency, just like you would with conventional ventilation minute volume, but your tidal volume is now used in a different way. It is squared, because they have found that CO2 removal is far more affected by the tidal volume than the frequency. So you take the tidal volume, you square it, you multiply the frequency, and the machine will give you that number multiplied together to give you the dCO2. And as your dCO2 goes up, your carbon dioxide goes down. Okay, so we like to think it's simple. It's not as simple as I'd like you to go and understand. So let's go and have a look at that. So how are we going to go and get that tidal volume up to get rid of our carbon dioxide? Well, the simplest thing is if you increase the amplitude, so those are the pressure fluctuations, the chest will wobble more and you'll increase the tidal volume. And if you increase the tidal volume and you square it, your dCO2 will go up and your CO2 will come down. So that's the simplest way to understand how to alter your carbon dioxide on high frequency oscillation, is by increasing or decreasing the amplitude. Okay, so if it was limited to that explanation, it will be very, very easy. So let's complicate it. Remember, the amplitudes that we're talking about when it's being measured at the ventilator is literally in the proximal ventilator circuit at the machine. Because these are moving so quickly, that pressure gradient does not get itself fully established further down the airway pathway. So when you get to the ET tube, you've damped it. When you get to the end of the ET tube, you've damped it further. By the time you get into the terminal airways, you may only have a pressure differential of, say, 1 or 2 centimeters. So here you've got a baby who at the ventilator, you've got a mean air pressure of 15, you've started your amplitude, which will create peaks of 35, troughs of -5, but it damps down, damps down, damps down as you go along the tube. So you've only got a gap of 2 by the time you get to the terminal airways, which is why you only get these small vibrations in the chest. And this will be dampened down progressively by any form of increased resistance along the airways. And that can include particularly your ET tube. A 3.5 and a 2.5 ET tube has a very different pressure differential as you get to the end of the ET tube. And when they've done some work looking at that, you get a 90% attenuation with a 2.5 ET tube, whereas only a 34% attenuation with a 6.5 millimeter ET tube. And this is taken from the SensorMedics manual. So you have to be very careful. You can't really pay that much attention to the amplitude set at the oscillator. You have to see what is happening at the other end, and that's going to be affected by the size of these babies' airways, including the artificial airways that we're using. So we talked about amplitude. You increase the amplitude, you get rid of carbon dioxide. You reduce the amplitude, you increase your CO2. What about the frequency? Do we alter the frequency? Well, I'm sure you all know that we do that, but this is where things get more complicated. So dCO2 is tidal volume squared times frequency. So we'd like to think that if you increase your frequency, you're taking more breaths. To your mind, you'll think that your dCO2 will go up. However, your tidal volume itself is interfered with by changes in the frequency. So if you change one item, it will then have an indirect effect on the tidal volume. So the two of them will now interact in ways which are a bit more difficult to predict. So the tidal volume is determined by the pressure amplitude as well as the frequency, and the frequency will affect the pressure amplitude as well. So it's complicating things. So how does frequency alter the tidal volume, high frequency? So here's a baby with the same amplitude setting here, same amplitude setting there, but the frequency is reduced. So it's very frequent here, very short time intervals between here and here. And then we're having a slightly longer time interval between each breath. Okay. So in this small period of time, only a certain amount of gas is being able to travel in, small amount of gas is being able to travel out. When we get to over this point, by slowing it down, more gas is traveled in, more gas is traveled out. So by reducing our frequency, we're taking fewer breaths, but the amount of gas that goes in and out with each breath has increased. So it's a double effect that we're seeing over here. So let's see this in practice. So here I've got a patient who's on a frequency of 11 and an amplitude set at 32. And I can see over here what the baby's tidal volume is that it's achieving on that amplitude of 32. So let's start over here. So frequency of 11. I'm now going to a change. So let's see what happens to the 143 dCO2, the 3.6. So I've gone from 11 to 8. So the amplitude stays the same at 33. But look what happens to the tidal volume. That's shooting up. Instead of being in the 3s, it's now leapt up to 5. And the dCO2, which was 140, is now shooting up to 180, and it may even go up even more. So we've come down on the number of breaths. So we'd think the fewer breaths would increase our dCO2, but in fact, the dCO2 is shot up because by giving more time for each one of those small breaths to go in, the tidal volume has jumped up. As the tidal volume has jumped up, this is a far more important measure than this one because you square it. So it's now 25 plus 5 squared multiplied by the 8. So that's why you're getting closer to 200 as a measure. Okay. So changing your frequency will alter your dCO2, but mainly because it affects the amount of tidal volume with each breath. The same will happen with increasing the frequency. So here I'm going to change from 10 up to 15, I think, if I remember rightly. And with that, my tidal volume, which is 4.8, is going to suddenly drop down. So we haven't got enough time to get the gas in and out. So even though our amplitude is still 20, the tidal volume on that has dropped right down from 5 to 3.4. And so our dCO2 will go down. So Increase in frequency causes CO2 retention. Reducing frequency gets rid of CO2. But you now have to understand your ventilator. So let's just go and give you a scenario over here. So let's see if this will come up. If you've still got your Menti open, 35 weaker, RDS. We've got a mean airway pressure of 14 on the oscillator. The amplitude is set at 20. Frequency is set at 8. IE ratio set at 1:1. Okay, and we are achieving that amplitude of 20. We've got a carbon dioxide of 10. What will be the simplest thing to do here to get the carbon dioxide down? Should we increase our amplitude, or should we set to try to get rid of carbon dioxide by using the frequency? Because we said that the frequency is a very powerful mode. What would people generally do in their practice? Okay, so I can see the responses are all showing pretty much what I would say here is increasing the amplitude. And we have a couple of reduced frequencies as well. Thank you very much for answering that. Now, I would agree with that. Just like conventional ventilation, we want to look at what our numbers are and our ranges. What are the sort of ranges we're thinking about? Well, here the frequency is relatively low at 8 Hertz. So that's 8 breaths per second. Whereas the amplitude is not particularly high at 20. So the simplest thing to get rid of the carbon dioxide is increase the amplitude. If you increase the amplitude, your tidal volume will go up, and as a result, the CO2 would come down. If you wanted to get rid of the CO2 by reducing the frequency, you're now going to be using really quite a low measure of maybe 7. It may work, but it's about what are the relative merits of one versus the other. It's just like with conventional ventilation. If you've got a patient on a rate of 80 on a ventilator and using pressures of 14, you wouldn't try and get rid of carbon dioxide by going up in the rate to 90, because it's already at the extreme measure of where you would be wanting. So you then try and balance it out by increasing your top pressures. It's the same as what we'll be using over here. Okay. Now in this situation, however, I've got a baby with RDS who's got a mean airway pressure of 16, so a higher mean airway pressure. The amplitude is set at 40. It's set at a higher value. Frequency is set at 10. So more normal for many people would say frequency for high frequency oscillation. So a high amplitude, relatively high frequency. IE ratio is set at 1:2. We'll talk about IE ratio later on. And you can see on the machine that the amplitude is not being achieved. It's only generating an amplitude of 30. CO2 is high. In this situation, how would we reduce the carbon dioxide? Would I increase my amplitude from 40? Would I reduce my frequency from 10? Would I increase my frequency, trying to get more breaths in? Well, I'm going to get confused with that. Or should I change my IE ratio to 1:1? So please let me know what you think you would do here. Increase your amplitude, reduce your frequency, increase your frequency, or change your IE ratio. I'm hoping that the Menti is still working. I'm not seeing any response here. I am slightly nervous. I'm getting a few. What my answers coming up as? Some B's predominantly. So reducing frequency. I have an increase the amplitude from 40. Okay, so at the moment, because it's not coming up on my Menti, I've obviously messed that up. The majority of answers are going to be reducing the frequency, because we've talked about reducing the frequency will be enabling us to get a higher tidal volume by doing it that way. And it may also, we're going to talk about the efficiencies of the machine now, but we have had a couple of answers saying change my IE ratio to 1:1. Now, I might be the sort of person here who would change my IE ratio to 1:1. So let's go and explain why that might be over here. Okay, so first thing we have to do whenever we're using a ventilator at high frequency is the ventilator achieving its settings? That's what you always need to make sure you're doing. Our oscillators are not the SensorMedics. On a SensorMedics, you set something, you get something. But most of the modern oscillators don't always achieve those. If you are achieving it, then fine. Let's go and say your amplitude, you're getting the amplitude, then there you can go and increase your tidal volume if you wish to. Your tidal volume, you can remember, you can adjust by changing your amplitude or your frequency adjustment. However, if you are not getting your settings, then you need to improve the efficiencies of the machine. You target those first. So that's a little bit complicated unless I demonstrate for you here. So this is a patient who's on high frequency oscillation. I've set my frequency to 11. Mean air pressure is 12. I'm on a 1-to-1 ratio, and my amplitude is set at 32. Okay, so I've set at 32. It's 32 over here. I'm going to change my frequency, and I want you to go and see what happens to the amplitude. I'd like to think that the amplitude would stay the same, and it's just going to be the tidal volume that changes. So I'm going to change my frequency from 11 to 15. So we think that the tidal volume is going to change, but what we also find is the ventilator's ability to get to its amplitude goes down. It was 31, 32, and for some reason, the oscillator cannot manage to get those amplitudes anymore at this frequency of 15. So the efficiencies of the ventilator are being affected. So by going up on our frequency, two things are happening. The tidal volume is going down because when you increase your frequency, tidal volume goes down. That's one mechanism. But another mechanism is happening as well. We are now no longer getting the frequency that we set. So you always have to go and check. We're not talking about volume guided high frequency. We're talking on standard conventional high frequency. You may set an amplitude. Doesn't mean you're going to get it. So if you're not getting it, you can increase this to 34, 36, 40. It's still going to be stuck at 26. 26 is the maximum it's ever going to reach at this frequency. So there are limits to the power of our oscillators, which the frequency imposes upon it. So the first thing you do whenever you're going to make a decision about what to go and change is, am I getting what I'm supposed to be getting? And if I'm not, I have to improve my efficiency of my oscillator. And in this situation, it might be you have to reduce the frequency to enable you to get that amplitude again. Okay, IE ratio is another one. We'll show that in a moment. So all ventilators are not the same, and ventilator performance can have multiple effects. Here you can see that this is the SensorMedics, this is the VN500, and this is at different, I believe at different IE ratios, these two graphs over here. And you can see that your amplitude that you can achieve, if you were to increase the frequency on the SensorMedics, you can keep that amplitude the same all the way through. So I've set it at 70. I've increased my frequency from 5 to 10 to 15, and my amplitude remains at 70 all the way through. It's incredibly powerful all through the range of frequencies. Whereas with my VN500, I start to increase my frequency, and there's only a certain limit that I can get on my amplitude, and so it starts choking it down. So I may set my amplitude at 70, doesn't make a difference. The only amplitude I'm ever going to achieve is 40 in this situation here. Okay, so it depends on what you've set it at. And you can see over here, as a result, my tidal volume will go down as the frequency goes up, but more so with the VN500 over here. So your own ventilator, you need to make sure, how do I improve the machine efficiency? Okay, so one way you can improve it is by picking the right frequency for that patient and for that ventilator. What about the IE ratio? What IE ratios do people use? Many people use 1-to-1. Many people will use 1-to-2. Certainly on the old SensorMedics oscillator, the teaching was always use 1-to-2 ratios in almost every patient. Okay, there'll be limited times when you use a 1-to-1 ratio in those patients. Most of the time it was 1-to-2. But they found that when you use that in the newer ventilators, the 1 to 2s didn't seem to work quite as well. So what were the concerns about using a 1-to-1 ratio early on? It was the feeling is that you're not giving enough time for expiration, and that may lead to air trapping. This was particularly at low mean airway pressures. And that's in particular in those early animal models where you're using animals with long time constants. So it takes a while for the lung to open and deflate with each breath. So because it takes a while for the lung to reduce in size with each breath, you will get air trapping in the expiration phase. And so you get stacking and hyperinflation of the lungs, particularly at the low mean airway pressure. So in the low mean airway pressure, then when you're sucking the air out, the airways collapse down and the air is trapped inside the lung. So they have to be very cautious. You have to give enough time for the lung to expire with each breath. Okay. This concern is not something more recent work seems to show unless you are using very low mean airway pressures on babies. And if you go and try to use a 1 to 2 on some patients with bad lung disease, you're just not going to be able to ventilate them. Here's an example over here. So this is a patient on a 1-to-1 ratio. And this is on a frequency of 10. And I'm hoping this is the correct example that I'm giving you. So have a look at the numbers over here. Amplitude of 32 with a tidal volume of 4. I'm now changing to a 1 to 2. So look at these numbers here. I've now gone to 1 to 2. So the 33 amplitude is starting to drop and is now dropping. So it's unable to achieve that 33 amplitude, and that tidal volume of 4 is now dropping down to 3.5. So I'm not achieving my amplitude. We must always ensure on high frequency oscillation, it's a bit like conventional ventilation. If you're using PCAC and if you set a pressure at 20, you expect to get 20. You should always do that. You wouldn't expect to get 14 when you've set 20. So it's exactly the same thing here. So you go back to 1-to-1 and you're back up to 37 again. So you need to ensure that you are getting what you're setting. Okay, so on HFO, just like PCAC, if you set a pressure, you should get a pressure. And if you're not getting it, you have to then work out how is it I'm going to achieve that, or do I have to go and decide this is not what I'm trying to aim for. I've set something unrealistic. Okay, so I generally will recommend 1-to-1 ratio where you have a ventilator where your power can be limited. So particularly with the VN500, especially where lung compliance is poor. So if you have stiff lungs with RDS, this is particularly where you have to recruit the lungs. A 1-to-1 ratio is important. 1 to 2 ratio is okay where you are using a low mean airway pressure for this baby. Then it's reasonable to use 1 to 2. If you're getting CO2 removal as an issue, despite using 1-to-1, and it's cystic lung, that's where you can use it, where you have a high airway resistance. So if your airways are issue, then you may need 1 to 2 because you need more time for expiration there. So if you think you've got air trapping, so especially extreme preterm babies who've got cystic looking lungs, I think this is where 1 to 2 ratio is okay. So the problem is airway resistance, not problems with compliance. If you've got problems with lung compliance, I recommend you use a 1-to-1 ratio in these situations. So how am I going to monitor my babies? We now know how we go and manage our lung recruitment to improve their oxygenation. We now know how to oscillate the baby, how to get that wobble optimally so that we can get the carbon dioxide out. If you're using a SensorMedics machine, what do people used to go and teach us? You do a chest x-ray at 1 hour. Although if you get to 18 centimeters of water before then, stop then and get your x-ray then, because if you're an extreme preterm baby, you may create very early cystic PIE very, very quickly. Do a gas within 15 minutes to avoid hypocarbia, because you have no idea what your CO2 is going to be. maybe do transcutaneous monitoring in these patients and do frequent blood gases. But if you have a way of monitoring that baby and you can get that tidal volume in that 2 to 2.5 mils per kilo early on, and you can keep an eye on the DCO2 to see if it goes up and down, then maybe you can wait a few more minutes before you do your gas, maybe 20 to 30 minutes. Okay. How do we know if lung inflation is good? We do the chest x-ray, make sure there's 8 to 9 posterior rib ends, make sure our pleura are not bulging outwards, make sure the diaphragms are not being flattened out, and an important one is that your heart must not be compressed. This is not displaying particularly well. Okay, so you have your initiation phase, initiate your HFO and optimize it. Adjust your mean air pressure with your FiO2 and with your chest x-ray. Make sure you get your gases stable, and then you decide what's your ideal FiO2 you want to aim for. And you pick that FiO2 and aim for that. Okay. You then respond to changes in the status of your patient. You may get this set up, but then your patient will change. The gases will change, the FiO2 will change, and you have to change frequently in response. So how often do you do your gases? Who knows, 4 to 6 hourly for some people, because CO2s can change very quickly if you're on the SensorMedics. Although if you've got a machine that's telling your DCO2, you can keep an eye on the DCO2 and it will tell you if you've got stability, and that will help. Some people will go and say, do an x-ray every day to make sure you're not becoming under-recruited or over-recruited. It's easy to get over-recruited in these patients, and then you've got cystic PIE. Some people will say that exercise where you drop the mean airway pressure until the saturations drop, and then turn it back up again to re-recruit is an exercise you should do every day to get the optimal mean airway pressure. And then you finally decide when to extubate. So this is the bit that can be quite tricky. How do you know you're at the right mean airway pressure? Do you do x-rays, or do you go and turn up mean airway pressure to see if the saturations improve, or turn down the mean airway pressure to see if the saturations are actually maintaining, in which case maybe you don't have to have that previous mean airway pressure. Then you may have lungs that are not homogeneous. And so this is a baby that I've got on the unit at the moment who I was oscillating only yesterday when I was on shift. And I've got this right upper lobe collapse. So what am I going to do? Can anyone go and type into their comments maybe some strategy I could use to go and try and recruit that right upper lobe? We've done suction, that's not helped. We've done positioning, that's not helped. Somebody's suggesting to me, right, this baby's on a mean airway pressure of 14. Shall I turn up to 15, 16, 17, 18 to recruit this bit over here? Who thinks that's a good idea? Any comments in the comments box? Seeing anything over here? So the wrong thing to do in this situation, chest physio is an idea. We've tried that. It's not got better over here. So the concern is if you increase your mean airway pressure 14, 15, 16, this may not reach the opening pressure of this bit of lung. And all you're going to do is you're going to hyperexpand this lung and cause cystic injury to this lung over here. There's some mention of selective ventilation. It's passing a tube down the right main bronchus that will probably inflate this lobe down over here. So the thing I would suggest in this situation, which I like to do, is use of sigh breaths. Now, there's not a huge amount of use of sigh breaths that are published out there. It's mainly in abstract form, and it's something that people have put down as their personal practice. They found that the use of a sigh breath, which comes every so often, maybe 3 breaths per minute. So the oscillator will carry on, and then 3 times a minute, it will pause, it will go and give an inflation breath, and it will go back to oscillation. And you can pick a number of times that happens during the course of the minute. Archives published in 2025 that when they did this in a selected number of babies, it improved the end expiratory lung volume for those patients. So it helped in recruitment by providing sigh breaths. Okay. There was another group who had a look at using sigh breaths as routine compared to some historical patients. So they set a PIP of 30 with an inspiratory time of 1 second. And they managed to recruit patients' lungs more effectively than just using high frequency oscillation. But with that, they had an increased risk of pneumothorax. And I would say a PIP of 30 is not the sort of thing you'd use in a preterm baby under normal circumstances, especially not held for 1 second. So for me, I would be uncomfortable about that. Jane Pillow, who is one of the gurus internationally on the use of high frequency oscillation, she set a protocol where they would set a side breath with a PIP 5 above the mean airway pressure, so relatively low, to try to help recruit that lobe. There are guidance provided Kanagawa in Japan and North Carolina. They use it as part of their routine strategy for RDS. So there are people out there who are now using in practice for their normal lung recruitment in babies, because rather than just keeping that mean airway pressure at a set amount to try and recruit the lung and turning it right up, just give the occasional breath to inflate and deflate, and that gets you up the curve more quickly. My own personal practice with this, I like to use it with this focal atelectasis. So that x-ray I showed you yesterday, I used it for that patient. So I use it with this focal atelectasis, or if the nurses are saying to me, every time they do suction on this baby, the saturations drop, the lung de-recruits, and it takes a long time for the lung to get back to where it started, I'll use it there. So I tend to go and use a PIP of 26, because I think for most of my preterm babies, that is the limit of where I like them to get with an inflation breath. Hold the breath for 0.6365 seconds, and I'll do 3 breaths per minute, and I'll see how that goes. But you may adjust that PIP up or down, the respiratory type up down, according to the lung vulnerability. If it's a big term baby with stiff lungs, maybe higher, but I tend to go and limit myself to those, and I like the use of those. Okay, remember the lungs though. Okay, we have to remember the lungs, not just a machine. We have to think about airway resistance, lung compliance, because these things will change as they go along. Okay, here's a patient, the patient's over here, the nurse does suction, and then she calls you and says, the baby saturations have dropped, can somebody help me over here? They suck out the baby, the lung collapses, they reconnect to the ventilator, the baby is now over here. So they're in a lot more oxygen, they can't understand why, so they do another bit of suction in case they've dislodged something, and you're stuck down over here. So in this situation, you have to do a recruitment procedure, turn up the pressure by 3 or 4 centimeters for a couple of minutes, and turn it back down to where you started. Another approach could be to use the side breaths, because when you do the suction and you come over here, the side breath will take you back up to the top of the curve fairly quickly. So it's a useful approach. Okay, here's a situation I've got. So hopefully Minty works. Apologies if it doesn't again. High frequency oscillation has been initiated for a baby with RDS. Mean airway pressure is 18. They're in 40% oxygen. And now the blood pressure is worsening. Somebody is starting some inotropes, and the baby's blood pressure is worsening, and their FiO2 is now beginning to increase again. What would you do in this situation? Would you like to increase your mean airway pressure because the baby's FiO2 is increasing? Would you reduce the mean airway pressure to see what happens? Would you go and do a chest x-ray? Or, I'll just throw this out there, would you put the baby on PCAC with volume guided ventilation? So, can we have some answers, please? And once again, I'm not sure I'm seeing this. Apologies if my Menti is not working. It isn't working. My apologies, that's not worked very well at all. So people may give different answers over here. What I would like to go and say is, even though it makes for some of you sense that you're thinking, probably the blood pressure's dropped because my oxygenation's worse and my FiO2 is going up, therefore I'll increase my mean airway pressure. Always resist the temptation to turn up mean airway pressure quickly, unless you have a really strong reason for believing that a baby has de-recruited. So if somebody has done suction and the saturations drop, and you know that will be dropping your lung volume, then it's sensible to increase mean airway pressure. Under almost all other circumstances, if you have a choice between increasing mean airway pressure or reducing mean airway pressure, always choose reducing it, because if you've got de-recruited lung and you reduce the mean airway pressure, your saturations will drop. It's an immediate response, and that gives you a diagnosis, because here our suspicion is that we are overinflated. As the lung improves in compliance, the lung will become more expanded on this high mean airway pressure. It will gradually drop your blood pressure. You'll need to use inotropes, and eventually as the lung becomes very expanded, then you won't perfuse your lungs and your FiO2 increases. It's a very common scenario in a baby who's been left on the oscillator on a set mean airway pressure, and people haven't been looking to wean it either with x-rays or this test I was talking to you about. Every so often, you reduce the mean airway pressure and you should expect to see the saturations drop. And that tells you in the right point. If it doesn't drop, you're probably on too high mean airway pressure. You can get an x-ray, and that will probably show that this patient is overexpanded. Okay, and that's the situation over here. And we've seen this so many times where you do an x-ray in a patient who's not had their mean airway pressure reduced, and they've now got cystic BPD, and it's going to be so hard to get that better. And it's a terrible picture. And then the heart squashed, and it's so hard to get the blood pressure up. These are a disaster when you have a patient in this situation. Okay, so you really want to avoid this happening. So turning up mean airway pressures is a very dangerous thing in extreme preterm babies. It's very easy to get that, because as your baby's lung compliance improves as they get older and the lung disease gets better, they've moved this curve to the left, so that previous mean air pressure of 11 where you were over here has now created a hyperexpanded baby. So you either do frequent x-rays to look for this, or every so often you drop the mean airway pressure, and if the saturations aren't dropping, it tells you you're not here, you're probably over there. So you want to test that de-recruitment every so often, even if it's only once a day, to see where you are over there. Here's a little trick I like to do, is if I've got a baby who's having a desaturation, and I'm not sure what I should be doing at this point. So I've got a baby on an amplitude of 30 over here, but more importantly, the mean airway pressure is sat at 16. The baby's having a desaturation, the blood pressure is poor. This is particularly for dope algorithms. So we all know how to do dope algorithms in babies on conventional ventilation. But I'm going to go and switch this baby now from the mean airway pressure of 16. The CO2 is not so good. The blood pressure is dropping a bit. I'm now going to put them onto PCAC volume guided to work out what's happening to this baby. Should I be worried about it? And I do a sense check, and I'm now on 5 per kilo on a PEEP of 4. And what do I find? I find that I'm using a mean airway pressure of under 8. So that tells me instantly, within a couple of seconds, that that baby's mean airway pressure of 16 was far too high. I haven't waited for an x-ray to work out what's going on. I can see at 5 per kilo, I'm only using pressures of 14/4 to get a nice tidal volume. This lung is now very compliant, has been fully recruited. So I like to do this every so often to test a situation where I'm not certain that I'm at the right point for my mean airway pressure, particularly if I'm worried I'm overexpanded or underexpanded. Okay, the same can happen in the other way around, and I'm just trying to go and check if this is the same one. I beg your pardon, it's exactly the other way. So this works the other way around as well. You've got a baby having a desaturation, they're getting worse, and you go and check them. I got you a mean airway pressure of 16. So I switched them to conventional ventilation, PCAC, 5 per kilo. And what do I find in this situation? Let's just have a look. The next thing I find, I'm using pressures of 37/5 to generate those tidal volumes. So I know that this baby's lungs are actually very stiff, and maybe I need to even turn up the pressure. So as I say, it gives you a nice sense check. Because our time is running a bit low, I'm going to avoid some of the question interactions, especially since the Menti wasn't working very well. But here's another situation where a baby has a sudden, almost a dope type event. The wobbles disappeared, and nurse calls you sudden desaturation after a nappy change. and you need to go and work out what you're doing. So in this situation, I'm now switching this baby to conventional ventilation. And what do I find? Let's jump forward. I have a very high resistance on my airway for a term. Let's say it's a term baby, a resistance of 324, and I'm not completing inspiration, expiration. Right away, I know that my ET tube needs dealing with, and I probably need some suction for this baby. So as I do make use of these switches back to conventional ventilation, because we're all very good at our dope algorithms, and we tend to lose the ability to do our dope algorithms when babies are on high frequency oscillation, because the graphics aren't very clever over here, whereas on conventional ventilation, I can straight away see over here that this baby has got poor lung compliance and needs more pressure, whereas over here I can see this baby has got flattened, longer curves, meaning that my airway is a problem and I need suction for this baby over here. So let's go into high frequency volume guided ventilation. So what is that? So that's the situation where, sorry, just bear with me. We'll let the ventilator now take care of the amplitude. Okay, I'm going to tell the ventilator, I would like this tidal volume, and I would like you to go and adjust the amplitude so you can take care of the tidal volume. It's just like conventional ventilation, where you use volume guided, but here the adjustment is in the amplitude. So it's not the mean airway pressure. You set the mean airway pressure, and then the amplitude, the ventilator will automatically adjust to keep the tidal volume the same. So as I say, I was giving you a number previously of maybe 2 mils per kilo for your tidal volume that you're going to use your eyes to see if you can get that originally. And then you're going to adjust that as you get your blood gases. But how about we start off with this baby at, say, 2 mils per kilo, 2.5 mils per kilo, and we'll let the ventilator achieve it with the amplitude. So this is something that's become more and more standard for some people to go and use. And for me, it's basically the only way I'll use high frequency oscillation. I set my mean airway pressure as usual. I'll set now an upper limit on my amplitude, just like on conventional ventilation, where you may set the top pressure on PCAC volume guided at 26. Here I'm going to set an upper limit on my amplitude, and I'll let the machine choose which amplitude to go and use. I'll set my tidal volume, so I will often use 2 to 2.5 mils per kilo. The oscillator will start the oscillating, and then after about 8 cycles, it will measure the tidal volume, and then it will adjust the amplitude to achieve that tidal volume. Why would we do this? Because we have found that it reduces the need of gases quite significantly. So I've gone, you go from, instead of 4 to 6 hourly gases, you can go to 8 to 12 hourly gases quite easily. And your chance of getting particularly this is our absolute fear, hypocarbia, can be almost eliminated. And that's personal practice. We found that, and certainly in the studies. So I think we did one of the first abstracts on the use of high frequency volume guided. This is an example of a patient. They were on high frequency with a set amplitude for a period of time. And within this, we could see that the DCO2 is up, down, all over the place. Then had conventional ventilation for a bit, and then went back, but with volume guided. And here, the amplitude auto-adjusted by the ventilator to keep the DCO2 static. And we know that with that patient, the CO2 was a lot more static over the next 4 days than it had been in the first few hours on high frequency without the volume guided. So it's a great advantage, I find, particularly for maintaining a stable CO2. The studies seem to show that as well. So from variability, this early study, having a look at extreme preterm babies over here. So this is looking at standard deviation, meaning with volume guided, less variation in saturations, heart rate was about the same, less variation in minute volume, and less variation in DCO2. So the CO2 in oxygenation was more stable. They were using a frequency of 12 and a tidal volume of 1.8 mils per kilo. So you can have the option of going for more breaths, a smaller tidal volume, or fewer breaths and a higher tidal volume. What should you use? Well, that's where decisions are being made at the moment. This study over here, one of the first proper randomized crossover clinical trials looking at high frequency volume guided ventilation, showed with the use of volume guided ventilation, you are able to spend 80% of your time in the target tidal volume area, and going above and below were far reduced compared to high frequency volume guided on its own without VG. And when they looked at their carbon dioxide levels, they found that with VG, they had a lot more patients in the correct zone, 5 to 7, compared to 21 patients. Only 4 patients compared to 7 were hypocarbic, and very few patients had a very high CO2 in this group here. So a lot more were in the aimed for zone compared to the other groups. So stability in your CO2, less frequent blood gas sampling, and less likely to produce gas trapping at a low mean airway pressure. So all benefits of high frequency volume guided. Okay, I want you to just think about this now. This is the bit, if there's one thing you learned from high frequency volume guided today that may slightly blow your mind, is remember we said I've got a patient who's got a high CO2 on high frequency, and I want to go and improve that CO2. So I can either increase my amplitude or I can reduce my frequency. Remember, if you reduce your frequency, you get a bigger tidal volume, so your carbon dioxide goes down. So what will happen in volume guided high frequency ventilation? Which of these will improve my CO2? Will it be reducing your frequency, like in standard high frequency oscillation? Or is it increasing your frequency, the opposite way around? Let's have a look. So this is a patient on volume guided ventilation. I've set my tidal volume at 3.8 mils, and that's what it's getting. I've set a maximum amplitude of 40, and the baby is only needing 30 amplitude to get the 3.8. So we're in a good place. We've got that. I do a gas, and I'm not happy with what I've seen. So I would like to go and change something, and I'm going to change it with my frequency, because someone's told me if you change the frequency, you'll change the tidal volume. I want you to go and watch what happens when I alter the frequency here to the tidal volume and the amplitude. Okay, so 30 and 3.8. So let's just play this, because the opposite is going to happen to what normal high frequency does, the exact opposite. So frequency is set at 10. Going to change that now to 8. So with that, I expect my tidal volume to go up 3.8. It does. It goes up initially. The ventilator detects it and thinks, well, that's more than 3.8. So it now turns down the amplitude to get that back to 3.8. Okay, so what's changed here? My tidal volume hasn't changed this time. It's not like high frequency oscillation without volume guided. Here, the tidal volume has stayed exactly the same as before I changed that. So there's only one change here. The tidal volume has stayed the same. The frequency has come down. So instead of getting rid of CO2, my CO2 has gone up. So this is the key thing you have to know with volume guided ventilation. Changing the frequency makes the exact opposite effect to your CO2 removal as on standard high frequency. Work is going on in high frequency volume guided ventilation and in high frequency, trying to go and work out what sort of tidal volumes are ideal. And the work is now suggesting that histology on animal models, you will get better effects using much higher frequencies, even as high as 20 hertz, 20 breaths per second, with a very low tidal volume compared to 10 and a higher tidal volume. Now that's fine, as long as on that high frequency, that gives you enough power to achieve what you're after. Okay, so the work seems to be suggesting if you can manage it, go for a higher frequency, lower tidal volume, but just make sure your machine has enough power to get that tidal volume that you're after. So what do? I pick my mean airway pressure as usual to start off. I build up, decrease down. During that time, I set my tidal volume, high frequency at the set value, depending on my baby, 2 mils per kilo. I'll set a frequency. maybe 10. Now, if you've got a big term baby, there is no way you'll be able to oscillate them on a Drager ventilator at 15. The machine is not powerful to handle a high frequency like that because it will only be able to generate low amplitudes. It just doesn't have a power. So you'll have to use, in a term baby with meconium aspiration, 7, 6, even 5 frequency to be able to achieve what you're after. But in an extreme preterm baby, a 24, 25 weeker, use 15, 16, 17 if you wish to, and a smaller tidal volume. And then you can wean the tidal volume as you wish if you're overventilated. Okay, so the better your ventilator, the more powerful. You can pick a smaller tidal volume and a higher frequency because you'll have enough power to achieve it. Okay, always make sure, are you reaching a tidal volume you've set? Or if you're not using volume guided, what amplitude are you reaching? Make sure your efficiencies have always been achieved. Okay, so I'm going to probably leave it at that because we've reached time, and I will open the floor to any questions.
Thank you, Dr. Boris, for this comprehensive lecture about high frequency. And I hope the time didn't stop and we can extend our session, but we spent more than 1.5 hours now. So please, if anyone have a question, you can write on the chat box and we can read the questions. Meanwhile, I can if I have one question about babies, like preterm babies with early PIE changes, which initially started on conventional. When you because I saw it a lot, babies like 26 or 25 weeks, then we, after 2-3 days on conventional, we start to notice PIE changes. Is this will be the right time to switch them to high frequency, or just you need to take care of your setting on the conventional?
Yeah, so this is certainly one area where I think high frequency can be of use. And sometimes we don't do it early enough and you come back and the lungs are hyper expanded, it's very cystic. And I find once you reach that point, then there's not a lot you can do about it. You're in a disaster zone. So I think certainly with the cystic PIE, by using high frequency oscillation, but accepting a higher FiO2, do not try to achieve an FiO2 of less than 30% because you will make the condition a lot worse. So use a lower mean airway pressure, accept a higher FiO2, accept a higher CO2, and in these situations, using a 1-to-2 ratio absolutely makes sense. Correct.
Okay, let us see any questions.
So,
Ms. Lav said, are you worried about too high amplitude? I don't know what she mean about, are you worried about high amplitude?
yeah, so the high amplitude itself doesn't worry me too much because it's how much of a tidal volume you get as a result of that amplitude, which is probably more important. I want to know if I've got a high amplitude. Why have I got a high amplitude? I've got obviously extremely stiff lungs, and it could be that I've not recruited the lung in the first place. And there you're worried that if your alveoli are not recruited and you're having to give a high amplitude, all you're doing is distending the small airways. You're not recruiting the alveoli, so you're going to injure your airways. So it's always important to have a recruited lung in the first place. Otherwise, amplitude is not going to achieve CO2 removal if you've got collapsed lungs. So always get your lung inflation done first.
So thank you. Dr. Mansour, you can say your question verbally, no problem.
Thank you, Dr. Bustani, for this great presentation. I'm using volume targeted. Do you hear me?
I can hear you, yes, Dr.
Okay.
Qureshi.
I use volume target high frequency for almost maybe 10 years now. But yeah, I think I learned a lot tonight from your experience. And now the issue is the essence of using volume target high frequency, that you use, lower tidal volume, and to have a good do CO2 and ventilation, you use higher frequency. What I see in my practice is increasing frequency, as you probably mentioned in your presentation, always you will have a significant loss of tidal volume, and you know that DC2 is tidal volume is squared by frequency. So increasing frequency will reduce your tidal volume, and because it's squared, the impact on DCO2 is significant.
Right.
So how to solve this issue. I had a baby recently, like this week. We started, let's say, tidal volume of like 2 ml per kg. We wanted to have a frequency, but once we increase frequency to 8, I mean, I tried to 1 ratio, but it didn't work. It does maybe allow you to have higher delta P.
Yeah.
But
So
I
mean,
think there is, I know the power of the ventilator, etc. But I think there is still the technology is yet there, maybe,
yeah.
to
Is that the
really, and that's my question.
Yeah. Is that with the
Maybe like
VN500?
600 or 500.
Yeah.
Yes,
So
yes,
I'm
exactly,
surprised that
exactly.
on a
So
frequency of
the
8. Sorry, I'm surprised on the frequency of 8 that you're not able to achieve a tidal volume of 2 mils per kilo, because I have to say, for my slightly more mature babies, let's go and say they're 32 weeks with bad lungs, 34 weeks, I'm going to use 8. For a baby that's term, I'm going to use maybe 6, 7, 8. For a baby that is extremely preterm, I'll use 10 to 15. So it's interesting that with 8, you're not able to achieve that. So I don't know what gestation baby you're referring to. And as you said, you need to, if you're getting difficulties, you have to use a 1-to-1 ratio in those patients, because you'll not be able to do it on a 1-to-2 if you're struggling with that. But you did say you're using a 1-to-1, is that correct?
Yeah, the thing that we need, let's say start even with 10 frequency, okay? Tidal volume, let's say 1.8 per
Yes.
kg. You will see the problem because you cannot see VT low. I mean, I thought it's a technical issue with the one machine, so we changed. We put 1-to-1. I mean, we started 1-to-2, but 1-to-1 it does help because
Yeah.
it will, the delta P will be higher.
Yes.
But still, okay. I mean, I found it, and I thought it is one patient or one machine, but it is very common.
Mm.
The essence, maybe you teach me that in volume target high frequency, the idea is to use higher frequency and lower tidal volume. So the essence of the high frequency will be more achieved to have a better ventilation. But I found this challenge of we
I,
cannot use higher frequency to achieve the tidal volume, and you will have, and you said the delta P, let's say 8 to 10 above the initial one, but you say, let's say set 50, 48, but it will only be 25, 30, so you would wish to go higher, but I don't think it's going higher, and that will result in lower tidal volume.
Yeah.
So I'm not sure in what I see is something common or other people see, but this is my experience with using this. I like it. I use it. I am doing currently a survey in the Kingdom of Saudi Arabia to see how is it prevalent use. Also looking at the what the challenges of using it, the learning curve. But I see this. I'm not sure if I am saying it from my
No,
own personal experience or something in
I agree.
literature.
And it is a problem. And there are current ventilators, I think, certainly the Dragers do have a limitation on that ability to achieve that. Although, as I say, that for the very preterm babies, it shouldn't be an issue. I think for the bigger babies, it certainly is an issue, and there you do have to go and use a much lower frequency. Otherwise, you run into the challenges over here. So if you're talking about less preterm babies, absolutely agree. You're limited by what you can achieve, and you have to use much lower frequency numbers. And I've used 5 or 6 in the babies who are a lot more mature, who have airway resistance problems, and it's a real pain. But this is where the SensorMedics was at its most of benefit in those bigger babies. But in truth, most of the time we are
Thank you,
managing.
Dr. Mansour. Thank you, Dr. Mansour. We have a lot of questions. So Amani is asking, would you recommend high frequency with VG in homogeneous or heterogeneous pathology?
Both.
Both, yeah.
Both, because in the
Yeah.
end, in real life, you have a tidal volume you're trying to achieve one way or the other. So I'll use it in both.
Another question from Dr. Saad is asking, what is the max and minimum tidal volume we can set on high frequency?
Enough to go and get your CO2 in the right place. The idea is minimize it within what your ventilator can achieve. So if you're going to have an option of going for a bigger tidal volume and a lower frequency, or a higher frequency and a lower tidal volume, and you can get the CO2 the same in both, go for the higher frequency and the smaller tidal volume wherever possible, but you may be limited by the machine. So I'd say 2 for me is a nice number. Many of these studies, they are trying to get down to 1.5. I think I struggle to go and do that in the patients I'm using it on. But 2 to 2.5 for most of the patients is an appropriate number. I think that seems to be sufficient. And then if you can then optimize it with a high frequency, enabling you to get down, brilliant. It can be quite difficult to do that.
Okay, another question, which is very common question about sedation with high frequency oscillation. Do you recommend sedation, or you can give only like very little amount of morphine, or let the baby breathe?
So my preference is sedation, but let the baby breathe. And I'll find myself saying to the nurses, oh, you don't need to paralyze this baby, just let them breathe on the ventilator. They don't go and interfere with it. And then half the time this baby will then splint and get agitated, and then you run into a problem, and then you end up finding that the baby gets paralyzed. So even though I'd like to go and say the answer is sedate the baby and let them breathe nice and gently on the oscillator, in reality, they can quite easily splint their airways on this, and then you end up having to paralyze them. But yeah, decent sedation. I wouldn't leave them. I tend not to leave them unsedated at all.
Thank you. Dr. Brahim Badran is asking also, thank you for the great presentation. Do you have an experience with starting with high frequency? I think we have babies we started on high frequency from the beginning, which is called early intervention. What is your opinion, Dr. Bustani, about this?
I don't. I like to know where I am with my conventional ventilation before deciding to go to high frequency. I don't think the studies have quite backed up that the high frequency mode is the ideal one to start off with, because the work that has shown what is the thing that is the best benefit for preterm babies has been PCAC with volume guided ventilation. So that's where the evidence base is for me. Until I've proven otherwise, that's where I'm going to start. However, I do know that when they're looking at 22-week practice across the best centers in the world, the Japanese will swear by high frequency oscillation for those small babies. And I think there's probably is a place for that. But high frequency done badly, I think, is far more dangerous than people who don't fully understand PCAC with volume guided. So that's why I think as a unit, I would prefer that we just stick to conventional. And then once you know the pressures you require, you know where you're aiming for if you then switch the baby to high frequency oscillation. That's just my opinion.
Yeah, thank you so much. Also, another question from Dr. Ahmed from Sheffield Children. He's asking, thank you, Dr. Bustani. He's asking you, can I ask what is the current defined entry point and exit point for high frequency? More than as what I am experiencing is considering high frequency oscillation as a rescue. I don't understand.
So certainly I was going to show the those sort of, certainly the exit points. For me, I tend to go and use when you have pressures of for a baby who's not achieving their volume guided CO2 targets on a pressure of 26, and you need more than that, and they've got vulnerable lungs. Certainly, I'll be looking to move out onto high frequency in that situation, or lower if they've got very cystic lungs prior to that. If it's certainly, we say the same thing on diaphragmatic hernias, don't we, is limit your top pressure at 25. And if you need more than that to go and ventilate a baby with a diaphragmatic hernia, then you should be moving across to high frequency. In those circumstances, I think that's fairly well accepted out there. When you then get to weaning the mean airway pressure, everyone seems to have a very different approach to this. If you're not very comfortable with high frequency oscillation, and particularly if you're finding that it's getting very easy to get this lungs overexpanded without you noticing. And some people will get down to maybe 14, 13, and they'll switch back to conventional ventilation because they're good at conventional ventilation and they know how to go manage the lung overinflation or lung inflation in those situations. More commonly, people I've found is when they get to about 11 or so mean airway pressure, they then switch across to conventional ventilation at that point. And I know there are some units who like to keep the baby on high frequency oscillation down to a mean airway pressure of 8 and then extubate directly onto CPAP from there. But that's never been my experience. As I say, I will tend to personally switch around a mean airway pressure of around 11 or so onto conventional. And the thing to remember is not how comfortable you feel as a clinician looking after a baby in high frequency. It's how comfortable are the people who are manning that unit when you go off shift in those periods of time in between. That's the point that you have to go and think about when managing these babies. It's very easy to overexpand these babies.
Thank you. Amani asked a question which was answered before. What is the maximum tidal volume? I think we answered this question. And Dr. Ibrahim, also, you mentioned about weaning. So I have one question, actually. Sometimes babies with hypoxic respiratory failure, and we fail with them on conventional, then we decide to shift to high frequency. And they didn't do well when with shifting to high frequencies. Then the people said, oh, they didn't like high frequencies, then let us go back to conventional. So how long you can wait to achieve, or how what is your approach for such baby? Because I didn't see like how we this is a gentle ventilation more than the conventional, and you can go with higher map. How the patient don't like it, I didn't understand it. So what will be your approach for this point?
And Tarek, I don't think the answer is a single answer for these babies, because I have that problem sometimes. You go and say, oh, this is going to be easy, go and put the baby onto high frequency, and they just don't seem to manage. And I do see that quite often in the babies with the cystic hyperexpanded lungs. And you think, oh, they're not oxygenating, we're getting difficulty getting CO2 up, and you try them with them and you don't get the effect you're after. You try to then reduce the mean airway pressure, thinking that's going to make a difference, and the baby deoxygenates, and then you put them back to conventional and they improve a bit. I've seen that too many times, and I don't have the answer for that. And I think often if your vasculature has gone past the point of no return, you cannot perfuse those lungs at that pressure because you become cystic. I find that's a real nightmare. Particularly when you have those babies with unilateral PIE, I find them the worst patients over there. Very hyperexpanded right lungs because the surfactant has gone down the one side. I find those the most difficult to manage that. I've had the same problems myself.
Thank you. Thank you for this nice presentation, very comprehensive. And I'd like to invite you more and more. We'll talk about different modes of ventilation, if you don't mind. And thank you for the audience. And let us meet again. And thank you so much.
It's been a pleasure. Thank you ever so much.
Thank you. Bye-bye. Thank you all, audience. Thank you. Bye-bye.
Thank you.
Thank you. Bye.
Thank you.
I'm so